Hi, I'm Dr. Triparna Sen. I'm an associate professor and the director of the Lung Cancer PDX program at the Icahn School of Medicine at Mount Sinai, New York. I'm an LCFA, Young Investigator Awardee, and I can't tell you how much the LCFA grant has actually helped me. But before I get into that, I have my friend here who is joining with me in this conversation. Jonathan, do you want to introduce yourself?
Thank you, Triparna. So my name is Jonathan Villena-Vargas. I'm a thoracic surgeon at Cornell in New York City, so we're neighbors. And in addition, I'm also an LCFA Early Investigator Awardee.
Yeah, thoracic surgeon, and you have a lab, right?
I do. I study mostly surgical resectable disease, so it's very niche for what I do.
Can you tell a little bit about your grant and how do you think that helped,
Sure. So I think, the LCFA was instrumental in kind of developing my lab. So, it's these high risk, high reward ideas that we have early in our career that, you can have the best idea in the world, but if it's not funded, you can't really go anywhere. Yeah. And so, a mechanism like LCFA that really takes a chance on early investigators, people that have not been tried and true, don't have these big awards or these big, large labs, taking that chance and getting that funding is really what opens up, at least for me, all the preliminary data that I need in order to enlarge my idea and apply for bigger funding and hopefully make a difference in patients.
Yeah, absolutely. So even with my grant, I study small cell lung cancer, which, as you're very well aware, is one of the hardest to treat cancers. Immunotherapy doesn't work as well as it should, and as you know, it is because small cell lung cancer is inherently immunosuppressed, and there is loss of MHC class 1, there is less PD-L1. So the grant that LCFA supported with me was actually looking at epigenetic modifiers like EZH2 and LSD1 and how inhibiting these epigenetic modifiers can then reactivate the immune system by upregulating MHC1. What that grant did, and it was an idea, like with any grant, it's just an idea in my head. I didn't have any preliminary data, so it wasn't even qualified for an NIH funding or a DoD funding, which needs, historically we know that we need more preliminary data there. I applied with just a hypothesis and some feasibility data, and I got the grant. And from there, the project really took off with that funding. We published a paper in Journal of Thoracic Oncology, a trial was launched, and then that actually led to my NIH R01 award. So the preliminary data and the paper and everything, it really helped me sort of build my team and build my program, so to speak, and get me my first R01. So I think you're absolutely right, and I agree with you that these grant mechanisms, especially the foundations like Lung Cancer Foundation of America, it really helps with us. Another thing that I have seen, and I'm sure the experience is the same with you, it also helps train the next generation of researchers, because in my grant, I could hire a postdoc and I could support a technician. The technician then went on to do a PhD, and my postdoc is, and he is now back in Japan doing his independent research lab. So it not just helped me, it also helped train the next generation of researchers. And I think that's the beauty of these grants. What do you think?
I mean, I think that's amazing. First, I want to take my hat off to you for studying first such a difficult problem, right? That's a really, small cell lung cancer is an incredibly difficult and treatment-resistant disease, very aggressive. So, I'm glad that we have good people studying that. And then second of all, R01 funding, which is amazingly difficult to get in today's environment, right? They say only 7%, 10%
yeah,
of
the PA line is terrible.
Yeah, only 7 to 10% of the people that apply actually get it.
Yeah.
And these are, people that have really robust labs. So I congratulate you for that.
Yeah, yeah.
But I agree, this foundational kind of funding, which is to get the preliminary data to grow a lab. Like for me, it allowed me to get a postdoc as well, and now have a tech, which is really important for me because I'm a surgeon, right? So a lot of my time is spent on patient care. A lot of it is on the operating room, taking care of patients pre and post-operatively. So, this kind of funding that allows me to have a little bit of cushion with regards to, who's actually doing the lab work, having the lab meetings, I'm able to, delegate a little bit more. That's really, really important, especially as a clinician and especially as a surgeon, which is really, really difficult.
Yeah, and research is my true north, as is yours. And we have seen, in these recent conferences, whether it's ASCO, World Lung, or ESMO, which I was recently at all of these three, I was so happy to see the advancement we are making in the field of lung cancer. We now have new trials and new approvals for small cell after a very long time. We haven't seen that, like limited stage small cell. We saw the Adriatic trial readout. It was practice changing. We have amazing ADC targeted therapies and T cell engagers come out. And I think research is what made this possible. Like 5 years ago, 10 years ago, we wouldn't have even thought about this much of advancement in such a hard to treat cancer like small cell lung cancer. And now we can. And I think research drove us there because the biology of small cell is difficult. And these new targets have come out from preclinical research. So I think grant funding and everything really helps support those basic ideas that can then be taken into the clinic. And for a clinician like you, I think you can go back from the clinic to the lab and learn from your trials, from your patients. Grant, I think, is incredibly useful. And for a surgeon, scientist like you, can you tell me how, the grant has helped you advance the field that, you study?
Yeah, no. Well, first of all, I completely agree with you. I think that lung cancer in general, I deal mostly with non-small cell lung cancer, has changed so much in the last 10 years, and it's all been research driven. I remember studying immunotherapy for the first time back in 2010 when I was doing my research fellowship. And really, those were the initial trials in melanoma, and we were studying immunotherapy, right? And that's when we really saw that it worked. And now you take it, 15 years later, where it goes from a mouse model to now all these major clinical trials that have changed how we treat, surgically resectable lung cancer has been amazing, right? It's almost hard to keep up because there's been so many changes, all for the better of the patient. And I think that's all grounded on foundational research, things like what LCFA kind of funds. So for us, as a surgeon, it really has changed. It has changed. We had 4 clinical trials even in the last 2 years. So basically, almost all stages of lung cancer are now treated with some sort of adjunct therapy. So I think that's been amazing.
Yeah, and we want to go faster. Everyone wants to go faster in research. And I think sometimes it feels like, oh, this is impossible. But I think we are just, we are doing the best we can with research. And I think the research will take us where we need to be. And I think the testament to that is this new class of drugs like antibody drug conjugates and T cell engagers that are really changing the overall response rate for patients. And also, we are learning so much about the biology. So I feel like, the areas of research where we could still be working on is to understanding primary and acquired resistance. I think that's an area that my lab is actively working on, is to understand, okay, we have these amazing therapies in the clinic, but patients eventually we see, unfortunately, resistance develop, either primary or acquired resistance. And I think that's an area where research my lab is working on, and many other labs are working on. And I think that could really help us understand. And we have to collaborate, like the basic scientists and the clinicians, they need to collaborate to understand, what are these resistance mechanisms for these even really well-performing drugs in the clinic. So, some of the ideas that you are working on in future for research, what would those be?
Well, I completely agree. I think, what I work on is very kind of specific, which is surgical resectable disease. But, just to bring it back to a point, I work on immunotherapy. We don't really know why it works and on who it works for, right? So we understand a very basic mechanism of why it should work, but that's not always the case. It's still kind of a little bit of a black box. So, trying to understand the fundamentals of a specific working drug, I think is really important. So, that's a little bit of what I'm studying, and what I realized as well is that as a surgeon, we treat a lot of patients. I operate on at least a couple of patients with lung cancer a week. And what I realized is that a lot of these, patient tissues, we're not really giving them full, due diligence, which is, Usually you send them off to the pathologist looks at it, you might do some testing on it, but we're not, taking all the information that we could be taking. So, our lab really tried to try to put a lot of effort into using every single part of this patient's tissues that are removed in order to study mechanisms of resistance or mechanisms of function. And I think that's really important, and interestingly enough, most patients are really okay with that, have them consent. I'm always surprised by how willing the patients are to help research.
Yeah.
And, we owe them a lot of, I'm very indebted to these patients because we discover so much just from treating these patients.
Yeah. Another area I think that grants really support is development of new technology. We have artificial intelligence right now that has, really catapulted how we look at radiographic slides, even digital path, where we can go into an H&E slide and really talk about the genetics and the transcriptomics of that tumor and also the prognosis. So I think, the more and more we do research being supported by these foundations, because these are high-risk research, right? So I think, having AI brought into the mainstream, also development of new technology like single-cell sequencing and spatial transcriptomics, which really lets us look at a tissue at an unprecedented magnification, and that we've learned so much about the biology from these newer platforms and new technology. And it could have never been possible without, research in the lab, which has led to these amazing advancements. And we can think about biomarker testing, we can think about NGS, we can do so much now, all thanks to research and the support that we get for that research.
Yeah, no, I absolutely agree. Right now in my lab, I have a bioinformatics person, and her background's all in computer science and mathematics. No background in immunology, very little in kind of basic biology. But now she's learning, but using something that's such a different skill set that I can bring or other people in my lab can bring, and helping with this sort of big data and AI and machine learning, which is literally what she's doing, because I don't know how to deal with hundreds of thousands, if not millions, of data points at the same time.
Yeah.
So I think that really has advanced things, and will continue to advance probably at an exponential rate on what we're learning and how we kind of deal with so much data in a kind of a very efficient way that can hopefully lead us towards good other projects.
Yeah. So you and I will come up with new ideas to progress the field of lung cancer, and we hope to get support from foundations like Lung Cancer Foundation of America, from the government through the NIH or DoD funding. So, any funding is imperative to progress research. And, I'm really fascinated about what you do, and I'm really thankful for what you do. So, I hope we can all work together to progress the field of lung cancer, I think.
Absolutely true. And I think LCFA does a really good job of bringing us all together.
Right.
Discussing these things and just kind of figure out ways that we can all collaborate. And, even though you work on small cell and I work on resectable non-small cell, there's so much overlap in understanding the biology and immune resistance and, all these things that you mentioned before.
Yeah. Well, Jonathan, surgeon, scientist, you must be pulled in a lot of directions. So tell me a little about your typical week, your typical day, and how does, grants like the one that you received from LCFA help you really focus on your research, and, how that has helped you, manage your time and all your effort?
Yeah, I mean, I think we all kind of wear different hats, right, in what we do. And really, as a surgeon, it's really difficult to do substantial research if you don't have the appropriate funding, right? Because there will always be surgery, there will always be patients to take care of. And what this funding provides is really kind of a foundation of help, right? So I have a postdoc, I have a tech. Like I was speaking earlier, I deal a lot with surgically derived tissues, right? So I'm operating on the patient. I take the tissues, and my tech will come into the operating room, take whatever tissues we need from that patient as I continue the surgery, and then they take them to the lab and have to do what they have to do. And that would be impossible if I didn't have that tech or that postdoc. So that's what the funding really provides, at least from my point of view, is the ability to, utilize every patient that I see, to get as much information from each patient that I operate on, and LCFA is fundamental for that.
Yeah. No, you were absolutely right when you said we wear multiple hats. Like in my role, I'm also the director of the Lung Cancer PDX program, which means I'm trying to build a program from ground up, trying to build that infrastructure, that communication with the clinic. So there's a lot of administrative duties involved with that. And then we have mentorship. We are part of different committees within our institution and also outside. I work very closely with other organizations, including LCFA. And then we also have different components of our research, like we are reviewers on grants, we are reviewers on papers. So I think what research has helped me with is really focus on the urgent, important ideas that we work on, and having funding really helps because you can then hire someone to take that idea, as you were speaking. So for me, it was the same. I could hire a postdoc and a technician to really bring my idea into fruition and help see that project come through. Whereas if we didn't have dedicated funding for that idea, I would probably be focusing on something else or be focusing on other duties, which are equally important. But the focus, I think grant really helps us focus our effort, our energy, our thought process into that really important and urgent question. And that has really helped me. And that has led to, as I said, bring a paper, of course, but then launch a trial and understand the biology of small cell. So I think it's incredibly important to have funding for your idea so that we get that sharp focus on that particular idea and we can actually take it to fruition.
No, absolutely. It really provides a lot of motivation, right? Like you were saying,
Yeah.
right? You have an idea, somebody believes in you.
Yeah.
And that's what provides that fire underneath you to kind of come in on the weekends, because I'm sure you do, because I know I do.
I do.
To work on all these things, add that extra kind of push.
Yeah.
It really is motivating to have somebody not only believe in your idea, but actually, provide funds for that.
Yeah. Jonathan, the grant that I got from Lung Cancer Foundation of America, it really helped me study the immune landscape for small cell lung cancer. As you know very well, small cell lung cancer is an immune suppressed disease, and there are various factors that contributes to that immune suppression, which includes low PD-L1 expression, cytotoxic T lymphocytes not being recruited properly, and also the transcriptional repression or suppression of MHC class I, which is so important for making the tumor cells visible to the immune system. So I think Lung Cancer Foundation of America grant really helped me study the factors that contributes to this immune evasion in small cell lung cancer, and then target those, target epigenetic modifiers like EZH2 LSD1 to then take out that repression, to actually make them more immune responsive. And we also showed in the paper that when you combine that with immunotherapy, you actually get very good response in the preclinical models, and later on it was taken on to become a clinical trial. So I think that really helped me develop that idea and things that I am interested right now, and I think that's where my research is going. I'm really intrigued about cancer evolution and heterogeneity and plasticity. So as you know, when the cancer gets treated, they evolve and they become more heterogeneous and they become more plastic, which means they change their features in order to adapt and become resistant to the therapies. So I think going forward, my lab is going to really focus on understanding cancer evolution, how that contributes to therapy resistance and heterogeneity of the tumors. I'm really excited about that. What about you?
Well, I mean, that sounds amazing. I think, you're understanding a mechanism of resistance and seeing exactly how to overcome it. And with immunotherapy, which I'm really a big proponent of, because you see it work in so many different cancers on so many different patients. For me, basically the major assumption that I made was that, a lot of people do trials or study advanced disease states. And then when that comes out as, like, let's say a positive trial, they try to get this advanced disease state and then kind of just, extrapolate it to an early resectable disease state. And I think that that's not really what's going on. I think that they're immunologically distinct states, right? In surgical disease, you're taking the tumor and you're actually removing it, removing the main antigen, or kind of what the T cells recognize. So that makes things distinct, it makes things different than advanced disease states. And that's kind of one of the premises that I really wanted to study. The other one is that, we all know that PD-1, immune checkpoint blockade, which works very well in non-small cell lung cancer in some patients, that it all works in the tumor, right? We know that mechanism of how it works on these T cells that are located in the tumor. But we also see that patients that, let's say they don't express a certain marker like PD-L1, it still can work on those patients. So I really wanted to study kind of these off-tumor mechanisms of PD-1 and checkpoint blockade. And that's why, I wanted to study the draining lymph node, because the draining lymph node, which is something that we remove on all the patients, also are a kind of a hub for, T cells and immune cells to be activated. And there's actually a completely separate mechanism of immune checkpoint blockade in the draining lymph node. So, the idea of studying these off-tumor mechanisms, I think, could be really important, because that could actually be the one mechanism that drives metastatic recurrence or protection from metastatic recurrence, which is the #1 problem in surgical patients.
Thank you so much, Jonathan. And I hope to see you soon.
See you soon.
Yeah.